moved to where you can see it. Now that we have this a new projector in there, it'll make your participation a little bit better. So we're going to go through mass casualty triage in reference to kids because it's not the same as with adults. We will, however, run through START really fast simply because understanding START is the beginning for understanding JumpSTART. Okay. So this presentation and the next presentation, actually, I do not take credit for. These are presentations that are available on the JumpSTART website as a reference. Dr. Romig is really big on pediatric disaster readiness, and so she works at Miami-Dade, or Miami Children's Hospital, and she puts all her information on the website for anyone to use at any time as long as you don't publicize it for money. So just keeping that in mind, if you ever need to reference it, these are available online. So when you talk about mass casualty incidents, you just need to understand what the tasks are, basically what the purpose is, and that will kind of guide your decision making. How many people in this room, 110%, say they could accurately triage using START right now? Right? Accurately, do you feel like you could, right now, if there's a disaster outside, go out and accurately use the START algorithm? No. Yeah, exactly. So, and I was the same way when I've tried to learn this so many times, and I will tell you, it didn't really sink in 110% until I started teaching it, because it's not something we use all the time, and if we don't use it, we lose it, right? So, once we talk about START, we'll talk about why START doesn't work for kids and how that prompted an entirely different system. So, right now, we're going to start out. I need a little bit of participation. The faster you answer, the faster we move on. So, outside right now, there's a bus or a train or some large vehicle. All those guys that were just in here are involved in a crash. We have to go out and here's what we find. So our first little guy is a boy who you find in the roadway about 10 feet from the bus. Those are his, that's the information you have just by looking to him. What do we triage him? A yellow, okay. You find an adult on the road, he's too dizzy to walk. That's his information. Perfect. Toddler is lying among the wreckage. You find him, and that's what the information you get. Anyone disagree with red? Okay. Red, yellow. You have a woman who's carrying an infant. She's able to walk. This is her information. This is the woman's information. Okay. You have an infant being carried by said victim, and that's the infant's information. Cool. Another school-age boy is on the side of the road, kind of sitting up. We have a green. We say red. We say yellow. You said yellow? I heard red and I heard green, so I heard one of each. Okay. We have a toddler outside of the bus, lying in a heap. Okay. School-age girl. I heard red. Okay. Yellow. Okay. I think this is the last one. And we're going to go over these after we review the algorithm, too, and see if our answers change. Green? All right. You guys did pretty good. There's a couple in there we'll definitely have to come back to and review. So basically, as we all know, triage is a sorting process. And on our everyday lives, triaging looks very different. As a general rule, we have enough resources to manage the amount of patients we have. We can move forward. We can give the best care to every single patient that we encounter. Now, when you get into a disaster, that looks very different. Because when you're in a disaster, you make a couple assumptions. One, you don't have enough resources to take care of everyone. That's just off the bat. The second assumption is that eventually we will, but that's later on down the road. So you're making decisions for the time being. Triage is a dynamic process. It's not triage once and then you're done. As we do this, we will triage at the scene. You guys will kind of sort them out, and then amongst the reds, amongst the greens, amongst the yellows, they'll be further triaged. When they get to the hospital, they'll be triaged again. Things change, vital signs change, resources change, and all those will affect how you're able to deal with these patients. So if you have a red patient that starts out that way, they may change to a black, they may change to a yellow. So in the primary phase of disaster triage, you are trying to recognize futility. People that you just don't have the resources to save right now. You're not going to waste your time. You're going to move on to the next person. And again, you assume that in a disaster, you don't have enough resources for everyone, but you will have additional resources later. So in that primary phase, what you're basically trying to ascertain is, does this person have the capabilities to take care of themselves while I take care of everyone else? And you're trying to figure out which people are going to benefit from the limited amount of resources. Once you get into the secondary disaster, what you're trying to do is match the patient's needs with what additional resources do they need. Can I take care of them in the field? Do they need to get to a hospital? And doing a triage based on that. Then you're really starting to look at reassessment of the physiology, their actual injuries, and hopefully knowing by that point a little bit more about who and what your resources are. So we talked about this. Again, patients with minor injuries are probably going to stay in the field until you can get all the sick ones out. Tertiary is really taking place in the hospital when you look at, if we were to have a pediatric disaster, some of those kids are going to have to go to adult facilities. Children can't take every single one, UT can't take every single one. And vice versa. When there's adult disasters, children's hospitals need to take one or two adults to offload from the rest of them. And so what's our definitive care after that, after we get them stabilized? We need to get that burn victim to a burn hospital. We need to get a pediatric patient to a children's hospital. So this is kind of what it looks like. You have your scene where you're doing your primary triage. You have your TARPs where you're, again, doing primary, secondary, tertiary, and then your hospital where you're mainly doing secondary and tertiary care, or triage. Interesting enough, as I was researching all this, there are many different tools for triage. The one that we use here in the United States most often is START, which is why we teach it all over the place. But there are many other options. None of them have actually been validated at this point. And the more we use START, the more we're finding that it's actually not very accurate in determining degree of injury in patients. Take Chattanooga, for example, that bus wreck that just happened. Some of their sickest patients ended up in green. There was a bleed in there, and there was a spleen fracture that went to green. Because what's the first thing we do when we triage patients? If you can walk, go ahead and follow me. Well, those kids can walk. They might be in excruciating pain, but they can walk. So just recognizing that this is a way to triage, it's not the end-all, be-all, and there are sometimes additional factors that play into identifying sick patients. So green, again, is the minor injuries. Yellow is potentially serious, but they're stable enough. They don't need immediate intervention. Red is life-threatening if you don't intervene right now. And then black are either those who are deceased or those who are expectant immediately. These are just a couple examples of triage tags. There are many different ones. Just depends on what one you use. I put this one up here because this is an important consideration. This is a pediatric tag. It's an adult tag. And one of the differences is this wristband right here. It's a wristband that you can rip off, throw on the patient, and then you can take one of these right here and kind of keep it in a separate binder and write, okay, this kid's going to this hospital, this kid's going to this hospital. And it's a way to identify your patients, especially kids, because sometimes they don't know their name, they don't know their date of birth, they know no contact information, and now you have this unaccompanied minor. When you triage, you always want to make sure to put your triage tag on your upper right extremity, and that is just so we're all trained to come up on a patient, look at their right arm. If they have a triage tag, the next. This is the initial phase, that primary triage phase. If they don't have a right upper arm, you go for the left arm. If they're missing both upper extremities, then you put one on the lower leg. So this START came out of a hospital out in California. Again, it's the gold standard right now, but remember that there's not a whole lot of evidence to even support that this is the absolute best way to be doing it. Has the 4 triage categories used on scene and in the hospital. And here's the bottom line for how you do it. We're going to go through it one by one. The first thing we do, like we all said, we're going to ask people to get up and walk away. Everyone else who's left, you're going to do them based on their RPMs. So their respirations, their perfusion, and their mental status. Forget that part. I forgot to delete that. So basically what you're looking for in your adults, are they breathing faster than 30? Is their cap refill less than 2? And can they obey my commands? So we're going to... all right, so... Okay, so you roll up on your scene and here's all your patients. And we're going to do this as a group with the understanding that when you actually come up on a scenario, you're going to do each patient individually one at a time. But this is just to kind of role play exactly what you're looking for and what you're asking. So step 1 in mass casualty triage is everyone follow me. Everyone who gets up, follow me. I'm going to take all you green people. We're going to go over to a safe space and you're going to stay with me. So the next step as you come up upon your next patient is, are they breathing? If no, if you reposition their airway and they still don't start breathing, they're black. You tag them black, you leave them where they are. You don't even go beyond that. If they are breathing, then what you need to know is you just bring them to the... and what you want to know is, are their respirations greater than 30? So maybe they were breathing when you rolled up on them, but they're breathing 44. Those people are red, right? So if they're not breathing, but start breathing after you position their airway, they're red. You don't go any further. If they're breathing, but they're breathing faster than 30, they're red. You don't go any further. You tag them and move on. So the next question, if you have a patient, you roll up on them, they're breathing maybe 20. You want to know, what is their cap refill? They're breathing at a good rate, but their cap refill is greater than 2. It might be 4 or 5 seconds. You tag them as a red and move on. You don't have to do the rest of your assessment. Your next patient is awake. They're breathing at 20. Their cap refill is good. It's less than 2. You want to... Sorry guys, it's so distracting for me. You want to know, can they obey my commands? If they can't, you make them a red, and then you move on. Now at the end, everyone who's left over are the people who are breathing. They're breathing adequately. Their cap refill's good. They can obey your command, but for whatever reason, they were not able to walk away because they injured their leg, because they're a little bit dizzy. All those people fall into the yellow category. And by the end of your triaging, you will have tagged everyone a certain color. And you're where you need to be, and you can start treatment. Now, in this triaging phase, if you were the first people there, your job is to triage. It is not to stop and treat, because the next person may be the sicker patient. So you need to, as quick as possible, get through and try and triage as many people. Now, hopefully you have people right behind you who can start treatment, but if you're part of the triage team, your job is to triage and move on. Now, any questions about that? Okay, so now we talk about kids. Kids are different, and the parameters that were set for adults don't work for children. So some of those concerns was that a respiratory rate of 30, which is the cutoff for adults, can be totally normal for kids. So right off the bat, our system for our pediatric population. Cap refill is not always indicative of a hemodynamic status. Kids get modeled because they're cold. They get modeled because they have a fever. So looking at cap refill in babies isn't indicative of what their hemodynamic status is, the same way as it is in adults. Kids don't always obey their commands. For every single one of you in here who has a child, you will know your kids don't always do what you tell them to do the first time they do it. Now, pair that up with some kids developmentally are just not able to follow commands. And the other part that's a really big deal, kids are more likely to have cardiac arrest or injury because of a respiratory component. So when you talk about a kid who was in, or a baby who was in a car accident, maybe was thrown, are they apneic because they sustained a head injury and they're bleeding internally? Or are they apneic because when they landed, they kinked off their airway and they're actually totally fine on the inside? So we have to ventilate them before we can make a decision on how sick they are. So the people who did JumpSTART, what they said is, okay, we're going to use START, we're going to use that as the basis, but we need to modify it to work for our kids. We don't want to create extra work for first responders and hospital staff. It has to work for all ages. What's normal for a 1-month-old is not normal for a school-age child when you talk about respiration rates, obeying commands, and all that other stuff. You want to try and minimize your over-under triage, and you shouldn't have to take more than 30 seconds per patient to triage them, because you might have 100 patients who need you. Just to drive home the point, kids are usually salvageable with adequate ventilation. So if you can get them ventilated, some of those kids will turn the corner because, again, they're debilitated because of lack of oxygen, not necessarily because of an injury. So what they decided is we have to add this ventilation trial for all of our apneic patients, pediatric patients. So same idea with the green. You're going to start by removing all your greens as much as you can, and then RPM still is what we're going to use to triage them with. So when we talk about respirations, in adults, we're looking for them breathing greater than 30. For kids, we're looking for less than 15, greater than 45. And the idea is that breathing anywhere between 15 to 45 can be normal for a pediatric patient. It's a very big range, I know, but that's the guideline that they give you. Instead of looking at cap refill, you're feeling for a palpable pulse. So for your older kids, you're feeling for a radial pulse. For your younger babies, you're feeling for that brachial pulse. And then instead of asking them to obey your command, you're going to use your assessment skills and figure out, are they AVPU? Are they alert, awake to verbal, pain, or unresponsive? Now, when you look at pain, you have to split pain in half because a patient who's appropriately responsive to pain is different than a pediatric patient who's inappropriately responsive to pain. Meaning, if I go up and sternal rub a baby and he starts screaming at me and pushes my hand away, that's very different than I do a sternal rub and the kid postures. So that's your defining line right there. Any question about this? Okay. So this is the algorithm. We're going to walk through it again. Anybody know who you're supposed to use JumpSTART on versus START? What's the age cutoff? 8 or so. Easy way to remember it, 8 is about the time that a pediatric airway starts morphing into an adult airway. Now, can all of you, 110%, look at a child and tell, yep, they're greater than 8, nope, they're less than 8? No way, right? So basically, if the kid looks like a child, use JumpSTART. If they look like a young adult, like these guys over here, you're going to go ahead and use START. Best you can. So let's walk through it again. Same thing. Anybody who can walk, go ahead and get up and follow me. We're going to come over here towards a safe space. Now this goes back to not all kids are going to obey your commands. You're a stranger. They're scared out of their mind. Why am I going to follow you anywhere? So as best you can, and this sounds silly, but make it a game. Who wants to come over here? We're going to play a game. Follow the leader. Make it. And again, I know it sounds so silly when you're talking about a huge bus wreck, but you need to get those kids away as much as you can. You're not going to be able to pick them out one by one. Everyone's seen this movie, right? I hope so. Peter Pan, follow the leader. Okay, so after that, you're stuck with all these kids, and they're all kind of laying about. They're all helpless. So again, we're going to talk about breathing, respiratory rate. RPM stands for R. If they're breathing, you want to know how fast are they breathing. If they're breathing less than 15 or greater than 45, you tag them a red and you move on. You don't move any further down on your algorithm. They're a red, that's it. If they're breathing normal and they're breathing 15 to 45, the next thing you want to know is, do they have a palpable pulse? Can I feel a distal pulse on this patient? you can't, they are a red. Now remember, they're breathing, and they're breathing adequately. So if they don't have a distal pulse, you really have a perfusion issue. Right? They obviously have a central pulse of sorts because they're breathing and ventilating. But so they're going to be a red. You don't do anything else with them, you move on. You come up on a patient who's breathing, they're breathing 20, they've got a good pulse, now you want to know what's their AVFU. If they are posturing with pain, tag them a red, move on. If they're awake, they're alert, they're breathing fine, they've got a good pulse, they just weren't able to get up and walk away, they're a yellow for the time being. Now, what happens if you come up on a kid who's not breathing? First thing you need to do is position their airway, just like an adult. So you position their airway, hopefully they'll start breathing. If they do, you kind of sort of leave them with a repositioned airway, you tag them and move on. Remember, the next kid needs you too. So you can't stay there and hold their airway open. Now, does that mean some of these kids may then start heading down the black or expectant route? Yeah. But again, you got 100 kids. You reposition their airway, they remain apneic. Do they have a pulse? This kid's not breathing, they don't have a pulse. We tag them black, we move on. Now this is where I feel like this algorithm gets a little bit difficult. So you have a kid who's not breathing, you reposition their airway, they're still not breathing. You check for a pulse, yes they do, they have a pulse, they're just not breathing. We need to give that kid 5 rescue breaths to see if they'll start breathing on their own. If they remain apneic, even if they have a pulse, you tag them expected and you move on. Which is very hard to kind of wrap your brain around, because if you could just stay and bag that kid, they will be fine. But unfortunately, again, you have 100 kids who need you. So you come up on them, you reposition their airway, they're still not breathing, but they do have a pulse, you give them those 5 rescue breaths, and lo and behold, they start breathing on their own, you make them a red and you move on. Any questions? Okay. Now, the other thing that we need to consider when we talk about kids and triaging them is the idea of our non-ambulatory kids. Our kids who are not walking yet, our chronic kids who are in a wheelchair, who just aren't mobile, and also kids with broken legs. So, when you have someone, say there's a mom involved in this accident and she has that kid in her arms. She's a green. She can walk. She feels fine. She's going to walk over to you with this infant in her arm. That infant has not designated themselves as a green, which means when that mom arrives to the green zone and you're manning that station, that infant is now your priority to triage, because you may find that that infant's actually red, and mom and him need to be moved over to the red tarp. Your yellows. You just got through that entire algorithm, now you have all these yellows. Once they get over to the yellow tarp, they need to be re-triaged, because there's going to be a good amount of those kids who are breathing fine, have good pulses, who are awake and alert and totally appropriate, and the only reason they didn't self-designate to green was they could not walk. They only crawl. They don't understand what you're saying. So if you are manning the yellow tarp, you need to look at the kids. If they have a significant injury, meaning they have a broken leg, they have, a partial amputation of their foot, doesn't matter if it's bleeding or not bleeding. If they designated to a yellow, they remain yellow. If they get to your yellow tarp, like this infant, they're totally fine, they just going to walk away, you're going to go ahead and move them over to the green tarp and re-triage them. Does that one make sense? Now, say you only have 15 kids, and you get through the triaging process really, really quickly, you've given any life-saving interventions to all your reds and your yellows, you can go back and reassess your blacks and maybe re-triage them to a red, or take over ventilations for that kid who just needs you to breathe for them. But you don't do that until all your reds and yellows are taken care of. And that is the JumpSTART algorithm. Hopefully I broke it down, it makes a little bit more sense. Again, it takes some practice and it takes some going through to kind of ingrain it in your brain 110%. What we're going to do is go through all those scenarios again, and answers changed, and a couple that probably will. So, we have the young school-age boy who's lying on the roadway 10 feet from the bus. He's breathing 10 times a minute. What do we make him? Red, period. We don't even care about the rest of the information. He's a red. An adult at the side of the road. So he's actually a yellow. So he can't walk, right? Because he's too dizzy. Oh, but is he too dizzy because he has a bleed? We're gonna agree to disagree on this because I gotta teach the start. But he would technically be a yellow. So toddler, you find them, they're breathing at 55. Red, right? Don't care about the rest of the information. The woman is carrying that infant. She's able to walk. She's green. What do you think about the baby? He's green, right? So this baby that, mom carries to the green zone is, his respiratory rate is between 15 and 45. He's got a good pulse. He's looking at his rescuer. He recognizes mom, which is age appropriate for that patient. He's awake. He's alert. And he's got no significant injuries. He's a green. All right, we got a young boy, respiratory rate of 28. He's a yellow, right? Perfect. Okay. So we have a patient who's, ding, 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 you gotta give him rescue breath. So if he's apneic, you reposition his airway and he remains apneic. If he has a pulse, you have to give him that ventilation shot. If he starts breathing on his own, he's a red. If he doesn't, he's a black. So don't forget to try and give them some breaths. Red, perfect, right? We're missing that. We don't have a distal pulse. We don't care what her APPU is. Yellow, absolutely. Absolutely. Now, if this said there was some active bleeding, but still had a good pulse, still was mentating okay, what would you do? Mm-hmm. So it's a little bit of a trick question because JumpSTART doesn't care if there's active bleeding or not active bleeding. It wants to know what is the hemodynamic status of the patient. Are they breathing? Are they mentating? And do they have good perfusion? Now, if they're actively bleeding and you don't triage or treat it, can they progress to a red? Absolutely. But in this moment, they're compensating, they're a yellow. But, exactly. You get into that yellow chart, that treatment area, they can throw a tourniquet on and be done with it. Anyone else?
They've all been served at least once. Everybody's been served on fire. Yeah. So I think maybe one last seminar to be thorough. Anybody who wasn't here today, our phone numbers are your chief's office and your director's office. Just let them know to go to them. We'll figure out. We just have to wait for the next service or something. We're already prepared to do that. Just let them know if we do have access to it. We'll get it covered. It's just the way it was created. Thank you.
Cool. All right. What about this young lady? Oh, our little friend left, didn't he? I heard yellow. She's green. She just can't walk, right? So when she's going to land in that yellow zone, right, because everything's normal, but all she's got is a couple cuts and bruises, and the reason she can walk away is because she's wheelchair bound. Any questions? All right, now you guys are all 100% on JumpStart? Okay, cool. Let's take, you guys want another break? We got one more lecture. Yeah? Okay. 5-minute break. 10-minute break. And then we'll come back.